Bismillahirrahmanirrahim. Hi everyone. This is the fourth video about abdominal pain, and we are still in the category where the imaging, including CT scan, is not diagnostic or not conclusive. And the last time we talked about the pathology being inside the abdomen. In this video, we're gonna briefly, really very short video, we're gonna talk about important diagnosis outside the abdomen, specifically above the diaphragm. So I will start with this case. I will just read it for you, and then I will leave you to think about it a little bit before I end my video with what happened with this patient. So we have an 88-year-old female with past medical history of pancreatic and breast cancer. She was in remission. Aortic valve replacement, atrial fibrillation, history of recent GI bleeding, so that the patient is not in anticoagulation, who presented to the emergency department for altered mental status and weakness, and she had a fall at home. That was 1 to 2 days prior to admission. The caregiver said that the patient was diagnosed with urinary tract infection about 1 month ago. She was treated with antibiotic. Vital signs in the emergency department was stable. Urine analysis showed leukocyturia, increased white blood cells in the urine, with positive nitrites and small leukocyte esterase. She was admitted as a UTI infection and started on IV antibiotics with resolution of her mental status, at least per the caregiver, by the time that the admitting team was evaluating the patient in the emergency department. So it was very brief and very acute. She denied dysuria, but endorsed right upper quadrant pain. That's per the evaluation in the emergency department again. This is the chest X-ray obtained in the emergency department, and the official read was mild to moderate interstitial opacities, may represent pulmonary edema or infection. Bilateral lower low opacities, right greater than left, may represent atelectasis or infection, small right pleural effusion. Very common finding in these patients. So you can see there's a lot of things going on here, but it seems like the main thing that happened to the patient was the fall and the very acute but brief altered mental status. And it seems like the patient endorsed right upper quadrant abdominal pain by the time of the evaluation in the emergency department. So based on that, the team did a right upper quadrant ultrasound, which was non-specific, and it showed just non-specific gallbladder wall thickening, but no stones. So to rule out acute cholecystitis, the team ordered HIDA scan, and it was negative for acute cholecystitis. It showed movement of the tracer inside the gallbladder. So think about what else could be done, what's going on here, and we'll talk about what happened to this patient by the end of the video. Now, causes outside the abdomen, as you have probably encountered before in some patients, a lot of important pathology that you have to think about in patients with upper abdominal pain. Cardiac is probably on the top of the list, specifically myocardial infarction, more specifically maybe inferior myocardial infarction. Think about inferior ischemia, inferior MI in this patient coming with upper GI symptoms, very vague, maybe dyspepsia-like symptoms. Also, other possibilities a little bit less common, pericarditis and myocarditis or myopericarditis. A patient with CHF as well, sometimes they might have big upper abdominal pain. We talked about the liver pathology. Sometimes congestive hepatopathy can also present as upper abdominal pain, right upper quadrant or epigastric. But sometimes patients with CHF might have also like some bowel edema, and that might give them some abdominal symptoms. So CHF is also important cause. Look for signs of fluid overload on exam, and also use point of care ultrasound. So for these patients, again, consider appropriate history and exam. Consider cardiac markers, specifically troponins. Do an ECG if the suspicion is there. Cardiac pockets would be very helpful. Chest X-ray, and also an echocardiogram if indicated. The lung pathology will include basal pneumonia, basal emphysema, pulmonary embolism, and pneumothorax. A lot of pleural disease. If the pleura in that area lower lobes in the right or left, they might present with predominantly upper abdominal symptoms. So keep that in mind, that these are very important. And in these cases, consider getting a chest X-ray, lung ultrasound also would be very helpful. Chest CT scan also if indicated. Patient with chronic coughing, they might have some pain in the upper abdomen, or even acute coughing if it lasted for a few days. You probably have encountered that as well. If you have forceful cough, you might have some upper abdominal pain. It's just musculoskeletal pain. And then thoracic cage disorders. These are less common causes. There's something called slippage rib syndrome, or sorry, slipping rib syndrome. Usually there's 9th or 10th rib cartilage subluxations, and these might cause upper abdominal pain. This is also known as lower rib margin syndrome. So it's a little bit less common, but it might happen. Another less common cause of abdominal pain in adults, it's more common in elderly, in pediatric population, which is tonsillitis. Many pediatric patients with tonsillitis might have some symptoms and abdominal pain. So in adults, less commonly so, but as you know, there's a lot of infections. We talked about that before. Infections, sepsis features that might have GI symptoms as well. So in general, again, ocular history and exam are very important, especially if they're presenting with upper abdominal pain. And one physical exam clue is that palpation over the area of the referred pain in the abdomen, mostly the upper abdomen, right or left or epigastric. Usually palpation of that area does not usually accentuate the pain, doesn't make it worse. And in many instances, actually, it might seem to relieve the pain compared to pathology is inside the abdomen, in the upper abdomen, that causes a genuine upper abdominal pain, like cholecystitis or gastritis. There might be some epigastric tenderness, right upper or left upper abdominal tenderness. But if it's outside the abdomen, usually, if you press in that area, it doesn't make the pain worse necessarily. But the patient is having the pain in that area. So just one clue. It's not like 100% specific or sensitive, but it's useful sometimes give you some clue that there might be something else going on outside the abdomen. Now back to the video, to the case before we end the video. So basically we went back, talked to the patient a little bit, we get a little bit more details. It seemed like the nature of the pain was pleuritic. She said that it was actually worse was inspiration and worse was coughing. Was a little bit suspicious, especially with the mild effusion seen in chest X-ray and the haziness in the right lower lung. So we ordered a D-dimer, and it came back positive. And we looked at her point of care ultrasound in the base of the lung, and you can see some effusion here at the base of the lung, pleural effusion. And going up a little bit, we found that she also had some B-line suspicious for pulmonary embolism. Let me show it to you here. So she had subpleural consolidation, looked like triangular in shape, associated with B-lines, as you always see with subpleural consolidation. This is in the right lower lung at the back. So that was all kind of really suspicious for pulmonary embolism. So we did CT pulmonary angiogram, and it came back indeed positive for pulmonary embolism. So this is what she had, and it seemed like that what caused her right upper quadrant abdominal pain. So it was a little bit challenging because she had GI bleeding, and she really was adamant that she didn't want any anticoagulation. After discussion with her and her family and her hematologist and oncologist, we decided to go with IVC filter and discharge her without anticoagulation. So this is just really kind of a classic case. I just really had this case a couple of weeks ago to kind of demonstrate that sometimes upper abdominal pain can be associated with pathologies above the diaphragm. So keep that in mind. And that brings us to the end of this video, and then see you in the next one, when we continue to talk about the causes that are not associated with findings or classic finding in abdominal imaging. See you then. Bye.